Hi, everyone, and welcome to CancerSpeak, which is the official podcast of the American Cancer Society journals. I'm Courtney DiNardo here from MD Anderson. I'll be your host for today's episode. I'm one of the section editors of Malignancies for the journal Cancer. I'm also a clinical researcher focused on personalized therapy for patients with leukemias in Houston, Texas. So I'm very pleased to be joined today by two experts. Our first is Dr. DeAngelo, the lead author of a new article in Cancer that presents a consensus statement from an expert panel of hemato-oncologists on the role of asparaginase in ALL, acute lymphoblastic leukemia. We know from previously reports that Frontline Blinatumomab combined with chemotherapy has both improved outcomes for pediatric and adult patients with ALL, is now considered really a cornerstone strategy for treating this disease. We do still have a lot of outstanding questions regarding safety and efficacy of asparaginase when used in diverse treatment settings, in particular with and without blinatumomab. So Dr. DeAngelo is here to talk more about this today on CancerSpeak, so welcome. And I'm also happy to be joined by one of the reviewers of this article, Dr. David McCall, who I will give the opportunity to introduce himself.
Thanks for having me. I'm a pediatric hematologist oncologist here at MD Anderson with Dr. DiNardo. I care for children, adolescents, and young adults with leukemia and lymphoma. And my clinical and research interests focus on incorporating novel therapies and treatment while minimizing toxicities. So this consensus statement really addresses questions we face frequently in clinic as these frontline regimens continue to evolve.
Well, thank you. Great to have you both here. So I'll start maybe Dr. DeAngelo with you. And I wonder if you can take just a few minutes to summarize the background for this consensus statement.
Well, this is really in light of development of pediatric regimens in young adolescents and adults. So I started focusing on this back in 2001 after Wendy Stock presented a beautiful paper where she looked at the differences in outcomes between patients enrolled on Children's Cancer Group trials, CCG, which is a cooperative group that no longer exists. It's now been COG, and Cancer and Leukemia Group B, now the Alliance, where she showed that although the remission rates are the same, the disease-free survival and overall survival was markedly inferior in young adult patients that were treated on adult regimens, and they were improved if they were treated on pediatric regimens. So back in those days, there was a referral bias. So if you were 21, 22, many centers still refer those patients back to their pediatric colleagues because they're the experts in ALL. But if they get seen by me, for example, back in the day, they would get an adult regimen. And so we have tried to incorporate pediatric-inspired or pediatric regimens into the adult world, trials at the Dana-Farber, trials from the CLGB by Wendy Stock, and now the Alliance trials, and the recent consensus statement from ASH this year, where young adult patients 39 and under should be preferentially treated with a pediatric regimen. Having said that, asparaginase is not the easiest drug in the world to use.
So I guess with that kind of a teaser that it's not the easiest drug to use, I wonder if you want to, either of you, whoever wants to take it, kind of talk a little bit about how we think about using asparaginase. How do we decide how to dose it, drug monitoring, and the various different formulations, I think, are also kind of key questions that I think a lot of people listening to this podcast or reading this article may be wondering about.
So I'll start, and then maybe David, you can follow as the adult oncologist, and I also treat in the United States. And this consensus panel was primarily pediatricians and a few adult treating physicians that were at an international pediatric oncology conference, which really prompted the use. And a couple things. So in the United States, the only regimen for upfront now is pegylated asparaginase. When I started, it was native E. coli. The big problem with that was allergies, and you would switch to the pegylated form. Now pegylated forms are preferentially used up front. They have the benefit of lasting several weeks, so you get prolonged asparagine depletion, but they are associated with some toxicities, hepatic, pancreatitis, thrombosis, to name a few. And one of the impediments or one of the issues is these antibody-drug antibodies and or silent inactivation necessitating therapeutic dose monitoring. And so we try to incorporate that into our consensus statement, being aware that in Western Europe, they have different asparaginase regimens and different backbones. And outside of North America, Western Europe, the access to some of these drugs, asparaginase and blinatumomab, which we'll talk about later, are limited.
Yeah, and I thought the consensus statement really mapped out this evolving paradigm of how do you use asparaginase, which is mainly pediatrics, in a world that's kind of merging things. So a lot of immunotherapies coming from adults, like we see Dr. DiNardo here at MD Anderson, and the data is coming out really thick. And so, and the consensus statement was targeted targeting that, it brought up ideas about how some people use less PEG, as you were just saying, and then also the levels, the different sensitivity levels. Is there room eventually going to be where if you're at a certain mark, you could skip a PEG asparaginase dose, or if you have a silent activation, is that a person that you would add a blinatumomab cycle to rather than and so it's a really nice evolving field, but it's also stuck in because I feel like we've studied the modified BFM regimen for so long. To augment that, is tough because our efficacy rates are so high. And so it's a good problem to have, I guess, but it's still, the more data we get, the more we're like, maybe we can tinker with this, but it's hard to get far from it because the rates are so high.
Yeah, no, I think you raised some interesting points. You're coming from a pediatric perspective. I'm coming at from a young adult perspective. But in the academic center, I think, what we've tried, more is not more. And the dosing of asparaginase that we use is clearly lower. And now with drug monitoring, that is much, much easier. We try to have some guidance over the minimal therapeutic dosing as well as kind of the maximal to target, with the idea that you may be able to give less in order to minimize toxicity. With respect to, to incorporation of blinatumomab, there are now 3 large randomized studies, one in the adult world using a slightly different backbone, but still asparaginase, the ECOG 1910, the COG regimen using a pure pediatric regimen in higher risk children, and then you have the infant ALL, which we did not address in our consensus because it's kind of a nuance. It's clearly that blinatumomab adds, and the question that you raise is, well, then can you start getting rid of? We didn't purposely address that specifically, but it led some guidance. We do think that the incorporation of blinatumomab is important based on pediatric and adult studies. And even though using a pediatric backbone, it can add to that. And so that's what most of us are doing, at least exploring in the adult world, is using our pediatric inspired regimens, very similar to COG 1731 that was published, and now incorporating blinatumomab into those regimens in terms of improving outcomes for the MRD negative patients.
Yeah, I think this is kind of the recurring theme in a lot of cancer, right? Is where we have all of a sudden all these new effective therapies and trying to figure out, you certainly never want to undertreat someone, right? But then, we have all these new things to put together and trying to figure out, well, what is the right combination dose and how many doses of any single agent is needed? I think these are some of the most important questions that we're trying to kind of answer as time goes on. I'll end with one final question, which I'll offer to both of you to just say, what do you think is maybe one of the most impactful pieces of information from this consensus statement? Kind of what do you hope the community is able to kind of glean from this that'll be really useful moving forward?
Well, I think from my perspective, there was good consensus, regardless of where you were practicing, realizing that the members and the committee were primarily Europe and North America, but there was good representation and good concordance with the use of and how to use a different asparaginase regimens and when to alter. So when there's silent activation or allergy with the pegylated form, there are opportunities now to use Erwinia or recombinant Erwinia, and when to use that, how to use that, with the idea that there's multiple studies, both in children's and adults, that if using a pediatric regimen, you really have to administer the doses that are designed. And in lieu of that, you get poorer outcomes. We also try to harp on that measuring asparaginase levels can guide one towards silent activation. What we did not agree on, and maybe David can attest to this, is there's different approaches in terms of prophylaxing for example, anaphylaxis. So most of the adult physicians, whether in the US, Canada, or North America, will often pre-medicate to minimize allergic reactions, but then you have to measure your drug availability. Most of the pediatricians in the United States and the Europeans on the conference, they did not do that. And so they let the allergy really guide them in terms of that. And so we try to lead some consensus. And I think this consensus statement on top of the ASH guidelines for treatment of ALL, I think really it dovetails nicely together. And so we didn't want to try to reduplicate what ASH is doing, but we try to augment what ASH is doing in terms of being a little bit more focused on the nuances of asparaginase preps, asparaginase doses, measurements, and then how to incorporate blinatumomab.
Fantastic. Dr. McCall, final words.
Yeah, thanks. I agree. And so I think with the consensus statement did a nice job on it, is really harping on that. Like, hey, this isn't just for specialized centers to use asparaginase levels. This is really something we should put more focus and into, looking at feasibility and logistical hurdles and like raising that conversation back up. I feel like a lot of people are led by the reaction, like you said. The other thing I like is how Blina can decrease your toxicity risk with asparaginase. I thought that was a nice statement because some people are worried about, like, what is the interplay? And then last, again, this looked at high income countries, low income countries, in that, what if we can't get Blina? Like, that's a great article, but like, how are you helping us? But you guys addressed that too. A great line, some is better than none. If you can get 2 weeks, great. And I think that's a really hopeful and powerful statement for people who are looking for anything to improve the cure rates. They're 50-60%, they're wanting to go up. So that was a great article. Thank you.
Well said to you both. That's all the time we have for today. I want to thank you both for taking the time out of your schedules to join us, and to our listeners who have joined us for this episode. I encourage you all to read this consensus statement, which is now published in Cancer, and we will include a link to this article in the show notes for easy access. Thank you all.